terms of glenoid bone loss? Is it only the size, or is it size as well as the quality of soft tissues, or the profile of the patient? Or is it the combination of all three which makes you decide?
Combination of everything.
So it's not only the size, it is the profile of the patient as well as Kapil said, Gege's sign and other signs of capsular laxity. So they will help you in deciding what is the future course of action should be.
I think the sex.
Sorry?
The sex.
Sex of the patient. Okay, could you please elaborate on that?
Female, like we did one 25-year-old doctor, and she had a 15 or 20% bone loss, but she was not a high-risk candidate.
So you could do
it.
Okay.
So there are always those gray areas.
So I think that will come in the profile and the patient per se. What's the requirement of the patient? So a borderline bone loss in a low demand patient, you can still get away with doing a soft tissue procedure rather than going for. Sorry?
No, the girls are better patients. They are more compliant. They have more discipline to physical therapy, at least in my opinion.
Better patients, better partners.
You want to add?
At least in my country.
Okay, Vivek wants to add something.
Yeah, no, I have a question to everyone else. You have mentioned quality of soft tissue. What is the predictor? I mean, apart from, let's say, some laxities, what is the predictor that when I go inside, I'll get a robust quality of soft tissue or a very poor quality? Do we have any predictors, Ashish?
Revision cases.
No, forget the revision. We are talking about
Primary.
like this.
It's difficult to
Like
assess.
he has written
It's
size as well as
impossible.
quality of soft tissue. Can we predict anything by any modality?
No.
The only point in favor I would take from that to factor into a decision was like that girl who we said, I don't know whether I can do Latarja Bankert. I'll go
Okay.
in and decide.
Okay.
So her labrum was good quality. Her bone
So
loss
that-
was 20%. So we did her Amplissage and Bankert
Okay.
because her bone.
In case the soft tissues were not that competent, you would have gone for
Latarja.
Latarja.
Done a Latarja for her.
I think with my short experience, I can say that quality of soft tissue has got nothing to do with repeated dislocations. Sometimes the quality of soft tissue can be atrocious in just 5 to 6 dislocations, which happened last week only before I came. And sometimes, what I felt that if the duration is long, let's say patient say it has been dislocating for last 5-10 years, then when you go inside, you find that the soft tissues are not so good
But
quality.
that's not
No, I
100%.
Yeah.
I mean, I just want to know
I think
do we have any predictor?
I think the more I don't know, maybe I stand corrected if more the number of dislocations. What my experience has been, the soft tissues, they are very, very poor.
But I have had some senior
This
colleagues.
is a tendency, but it's not mandatory.
It's not mandatory, obviously.
It's
It's
not
not
because
mandatory.
we've done 30, 40 times dislocator, still done a Bankart. But some surgeons use this frequency of dislocation as a justification Latarja.
Yeah.
Is not correct.
Yeah.
Is not correct.
I fully agree.
But nevertheless, you should be prepared for Latarja. If
Yeah.
somebody is
Yes.
dislocating in sleep, somebody is dislocating 34 to 40 times.
Partly correct, Amit, but imagine a scenario where somebody is dislocated 30 times.
In
And-
sleep.
Okay, 10 times of which is in the sleep. They have a 5% bone loss. You're going to do a Latarja without a bone loss. You're going to overtension that subscap and make them more stiff. So, doing a Latarja in the absence of bone loss is a no.
It's overkill.
It's a no-no.
Ashish, that is absolutely understandable. But don't you think every time shoulder moves, the humerus moves out of the glenoid, there is some attritional bone loss? And the more the number of dislocations, the more the patient, the chances are that he'll have more attritional bone loss.
But just
It
do
may
a-
not be linear, but there is a relationship.
Just do a soft tissue procedure, relocate the head to the center. Sure.
Amite, we just finished an analysis analyzed by one of the undergraduate students, and we have come to a conclusion that number of dislocations has nothing to do with bone loss.
That's
So
very
how do you
interesting.
come to it? Because
That's very
if-
interesting.
If somebody is dislocating 30, 40 times in sleep as well, I mean,
Number of dislocations
physically-
and sleep has got nothing to do with type of lesion, amount of bone loss.
sleep is just telling you how easily
How
it
easily
comes out of the cup.
Okay. That is very interesting, Vivek. I think when obviously it must be under publication somewhere. It will add to
It's
the
not
literature.
The publication is just he has finished the analysis.
Okay. But as far as current literature says, the chances of bone loss are more in case the number of dislocation, and in case the ease of dislocation is less. It makes sense actually.
It's on every patient.
It makes sense.
It makes sense.
So, no, it makes sense, but that's what is very surprising. This is how I started
There's no
thinking
linear
that
correlation.
There's no linear correlation, that we can agree. You want to add anything, Kapil? Okay. Okay, I think we have discussed this. Attritional bone loss, go for Latarjet in case that is significant. In case bony Bankart, which is about 20%, you can incorporate that into your repair. Okay. Okay, so how many of the panelists here believe in the concept of engaging Hill-Sachs? Can you just raise your hands? How many of you believe? They all engage. You don't believe in engaging non-engaging Hill-Sachs?
If there is a Hill-Sachs, it has engagement.
Okay, so non-engaging Hill-Sachs is non-existent.
Engage at once at least.
Okay, so you don't agree with don't agree with De Beer and Burkhardt, the concept of engagement in this position. Okay, so all right, so I think
Can't
this
make
this
an
was
omelette without breaking an egg.
this was an engaging Hill-Sachs as per the definition given by De Beer and Burkhardt. The concept of engaging Hill-Sachs for the audience is which may not be true, is the one which engages in this position of abduction and external rotation. Okay, so what do you do so how do you identify a significant Hill-Sachs? In case you don't believe in the concept of engaging Hill-Sachs, which according to De Beer is the one which engages is a significant Hill-Sachs. So how do you decide that this Hill-Sachs is a significant which merits attention? Ashish, what do you want to say on that? How do you say that this is significant? Because all Hill-Sachs, according to you, engage.
The jury is completely out on this. Honestly, maybe you've studied this for a long time. I started doing Remplissage since about a year and a half now. Now, our MRI technicians do a CT scan and give us a percentage of the Hill-Sachs of mine. This 30%.
So it's a circumference, how much of the
We calculate the
area of the humeral head?
Plus a percentage,
Okay.
and so anything that's 16 mm should undergo Remplissage. But if it looks very lax and is coming out and very impressive, I would do a Remplissage. There's a huge body of work being done by I.G. Toy and Gianluca Giovanni from Rome, and they have described the glenoid tract.
That's what's
The area of the glenoid that
yeah.
impresses on the humerus.
That's the glenoid tract.
Yeah.
Long story short, we used to think that a deep Hill-Sachs is more dangerous.
Yes.
Their suggestion is a wider Hill-Sachs is more dangerous.
Yes.
A medial Hill-Sachs is more dangerous.
Yeah,
So
the
we
Hill-Sachs
have
which
more
goes
medial-
beyond this glenoid tract. That
It's
is
still
what.
eyeballing.
Yeah, there's no preoperative
Strong, rigid measurements to say this one requires.
Sure, but what I would say is that the glenoid tract, that is an Asian toys idea,
Yeah.
if you reestablish this with a Bristol or with a Latarjet, it will work regardless of the size of the Hill-Sachs. I have the.
I agree.
That-
But then should you do a Latarjet for all Hill-Sachs?
No. I'm just telling you
Sir-
that once you do this surgery, it will work regardless of the size.
Yeah,
of
that
the
is
Hill-Sachs.
understandable, Sergio. But may I ask you, what makes you think that this particular Hill-Sachs is a significant Hill-Sachs? Is it the size? Is it the orientation? Is it the depth?
It's the size, but I would just make a small comment. I trust a lot in Christian Gerber. He's alive. He lives in Zurich, and he's a fantastic guy. But he has an idea that sometimes you must fulfill the defect with tricortical iliac graft. And I fully disagree, because once you reestablish the glenoid tract, you must do nothing, even you don't have to do a remplissage, and these guys will be okay.
Yeah, but
Oh.
if you take a Hill-Sachs that is a hatchet-shaped Hill-Sachs,
You mean
then
40%?
that is the one that requires a graft, not the smooth, round, circumference.
Yeah, so the point that is coming forth is all Hill-Sachs are not same, and
No.
the Hill-Sachs also vary in terms of their depth, shape, and orientation, and each one should be tackled separately yes. Yeah, Kapil, what is your procedure of choice for significant Hill-Sachs?
For me, the significance is the breadth of
Okay.
it. And if it's a significantly broad Hill-Sachs.
How much?
then
How much?
I think it's more eyeballing and.
Okay.
I do put it in the abduction external position, but what I was going to ask you is, how do you look for the engaging? Do you do it before you put any saline?
Before the saline, yeah.
That I think that's very important for the.
Yeah, before the saline.
Yeah,
The
because-
concept of engaging and non-engaging is don't put any saline and just do a dry dynamic arthroscopy and then decide.
Their scope.
Yeah.
Yeah.
Their
So
scope.
if I find that it's too broad a lesion, which is when I put it in there, it is going to be coming very close to
The
even if it's
glenoid.
not dislocating. I've got a low threshold of converting to a lateral.
Okay.
I don't do remplissage, I do a lateral.
Okay. Another very important point that is very pertinent here is, I was listening to E.G. Etoy in ISACOS, and he said the incidence of remplissage because of this engaging, non-engaging hill sacks is very high nowadays. What we suggest, what he suggested is, do a Bankar's repair and then see whether it engages or not. Because what happens after Bankar's is the hill sacks which was engaging prior to the Bankar's repair stops engaging, and your chances of doing remplissage would go down substantially.
That's very nice idea.
Because
But
the head comes
in
back to
theory, it
place.
is nice. In practice, it is not, because doing the remplissage becomes difficult. So let me tell you on that. We started doing that, and because we
Now
are
put your anchors first, but don't tie them.
no.
Yeah, but you are married to that, yeah, you'll have to
I
do that.
guess once you do the labrum, most of the times you will
It
not
becomes-
need to. So one delegate asked me at one of the IS meetings, how frequently do it? And I said, I don't have an answer. So we went back. We are doing it only 25% of our Bangalore repairs.
Okay.
1/4.
But that's quite significant. That's a significant number.
3/4 you don't need to. Now you have black and white cases. You have a massive hill sacks. There's no contest. Do the remplissage and then do the banker. Then with a small hill sacks, definitely don't do the remplissage. Just go ahead and do.
Sure.
In the gray areas where you're not sure, then do the banker repair and then struggle with the remplissage if you need to.
That's a very important point. Vivek, what's your procedure of choice for significant hill sacks?
That's the problem. That procedure of choice, we don't have many choices. We have only one choice at the
Lateral.
moment. That's the remplissage.
Remplissage.
I
Okay.
have never tried graft, and I am not at all keen understanding.
You don't believe in-
hatchet shape, because you are putting a bone piece in the place where there was actually a cartilage. So I don't know in future what will start happening. when
Okay,
you
the
start
grafting
doing-
for the defect you are saying.
Yes, I'm
But
not very sure.
what about extending the articular arc, the DeBaer concept?
Osteochondral graft. We use an allograft for the
Taken
femoral
from,
head.
taken
Yeah, I
from,
mean, I have.
Femoral head.
Yeah.
huh?
We have lots of femoral heads
Femoral
because we
heads.
But a
buy
bony bank.
The osteochondral grafts for, okay. Any thoughts on doing Latarjet for hill sacks? Although it's a non-anatomic answer.
Non-anatomic answer. I mean, the defect is somewhere else and you are reconstructing something else.
Most of the moderate hill sack have been replaced. The one that you showed earlier, it also has got venous defect. And the same one that you showed me, like the L-shaped defect. Most of them, they will also have venous bony granule also, bony banker. So we need to address the bony banker first. And then think about addressing that. I'll be doing remplissage for the
Remplissage. So what comes out of this discussion is, I mean, there are very few followers of doing Latarjet for hill sacks. In case there is significant hill sacks, go for remplissage along with the soft tissue procedure. Okay. Okay. I'm sure most of you would be doing Latarjets. Now, there is a paper in JBJS last year which reports on the complications of Latarjet, which are to the tune of 40%, which is quite alarming. So,
Warner's unit.
yeah. So what in your hand has been the most common complication of Latarjet?
So you always ride a curve and you think you are the best, and then statistics pulls you down. So there's nothing like a good follow-up to ruin your success story.
Yeah.
Okay.
So I went to Joe DeBeer in 2005 thinking Bankard is the best solution for instability. He pulled me down because he was doing everything Latarjet. Came back, started doing CT scans like he did and saw the amount of bone loss. So we started doing Latarjet. Phenomenal success stories. We've had the #1 wrestler in India doing Latarjet, getting back his gold medal.
Yeah.
#1 javelin going back to #1 position. #1 military cadet from IMA Chennai coming back with gold medal. And we sorted out. And then we put up a research study sponsored by the hospital ethics committee of Blue, doing CT scans for all our Latarjets. And our last fellow did that and compulsorily got all the CT scans for everybody done, minimum 3 months post-op.
Mm-hmm.
And we saw everything.
What?
We saw
Non-union.
everything.
Just
Now,
bring.
we had 2 fibrous unions, 1 non-union. Once that non-union patient had a screw bent, he's still doing fine. He's
A broken
not
screw?
No, it's bent. It's
A
not
bent.
broken, but it's not united.
It's
And
just a
he's
matter of time.
1.5 year down the line.
Yeah, in non-union, the implant will.
1.5 year down the line,
Yeah.
he's playing cricket for Baroda,
With
and
no
he's
pain.
not ready to take it out. And I'm pleading him, come back. We need to take it out. He's terribly. He said, I've never had such a strong shoulder. We also, along with that study, we tested the positions of the graft.
Yeah.
So we described 3 positions: plus position, which was proud,
Proud.
0, which was ideal, and minus, which was recessed. So we had few recessed, just 3 out of the 60 that went were recessed, and then there were almost 18 that were proud, By minor, we were very hard on ourselves. So 2 mm, 5 mm, they're all proud. Screw metal were prominent, articulating with the head in extreme positions.
So
and
this-
osteolysis had started at 3 months.
Despite being
None
this
of
being a
them-
vascular graft.
The fact is, all of them had some osteolysis to a lesser or a greater extent. And Gianluca's work is 1.5 years after the lethargy. He's shown extensive osteolysis.
Yeah.
So if it starts at 3 months, nobody's done osteolysis in
Studies.
at such soon
Yeah.
acute situation. So I can tell you it starts at 3 months. So I mean, we do fantastic work, fantastic results, and this came as a shock to me. We've had one brachial plexus which recovered completely, and we've had.
Isolated musculocutaneous. Do you isolate musculocutaneous in all the cases?
I always do.
Do that.
Always do. Because trained by Joe Beer, because sometimes the musculocutaneous nerve enters 3 centimeters
Yeah.
into the short head. 3 centimeters, then you cannot mobilize it to reach
Below
the tip of the coracoid.
Okay.
So
But you isolate
usually,
Always,
yeah,
always.
You always see it.
Always.
yeah. That's the recommendation by De Beer. You
But
must.
don't know which ones have a short entry point, which ones a long entry point. We've had only 2 patients where it was a short one, and so we converted it to.
How many pulses have you had of the biceps?
Oh no. We've had 1 brachial plexus neuralgia.
No, but I mean muscular.
No muscle.
cutaneous.
We've had no muscle.
Okay, that's very interesting. Ashish, thanks for sharing that the lethargia is not a panacea, so there are complications associated with
It's a very
lethargia.
difficult surgery. Even in my hands, I'm stressed out. Bangard is easy. I'm
Okay.
honestly, he's being very honest.
Thank you. Anyone of the panelists would like to add to the complication that you have encountered in your practice?
Can't add anything after.
Okay, okay, thank you. Okay, case number 4, 18-year-old female patient, a student, unilateral shoulder complaints, no history of trauma or episode of dislocation necessitating reduction, gives history of shoulder giving way and slipping out during day-to-day activities. She is a non-sports person, and there is no history of instability during sleep. And that's the clinic, that's the Baton index being done, so thumb and fingers, so it was 6. So there was generalized ligamentous laxity. Direction of instability was anterior as well as inferior. Sulcus sign and all these signs were positive. There was increased ER. There was Gege sign was positive. Sulcus sign was 2+, and apprehension anteriorly as well as inferiorly was positive. So X-rays and MRI are normal. So now, how would you approach this patient, Subal? So what is your diagnosis? Because everything is an academic exercise. So this is for the audience. What is your diagnosis in this type of a patient?
Patient's ligament laxity is Baton score 6/9. So she is having a ligamentous laxity type of, which is multidirectional type of instability.
So this is a multidirectional instability.
The
Yeah.
Madsen type is Ambry type. My view on this is try not to operate as much as you can. Keep on going with rehab measures, physiotherapy.
Okay, so I think all of us would agree that this patient should be subjected to rehab program for some time.
This is what I learned in Brazil. Send to your best enemy.
Okay, Subramanian, what's your rehab program for this kind of patient?
Scapular stabilization and rotator cuff muscle strengthening in systematic way, isokinetic strengthening, cervical theraband strengthening.
And for how long would you like to continue this rehab?
Asked her to go for 3 to 6 months.
Okay. Anything that you would like to add?
So about 6 months. The only thing in the history you said it was only anteroinferior. There is no history of any documented injury at all?
No.
Because in on the Stanmore triangle, is she pure multidirectional? She's not multidirectional. Is she pure intramatic?
She's I would say.
And the investigation you've had is a plain MR, unless you've got
No arthrogram.
Unless you've got the best MRI scan in the world, which our friend has. I would have done an MRI.
MR arthrogram, okay.
To rule out a structural
Any structural lesion, yeah, that's a very important
She's got
point.
a structural lesion on top of ligamentous laxity, because
Then-
we should not condemn her that
Yes.
way, because she's unidirectional at the moment. That's
Okay,
the only way.
okay, okay.
So when you advantage of the MR arthrogram would be what? A haggle and a slab.
No,
MRI would miss a Bangard, you know.
Yeah, MRI would not miss a Bangard. Labral tear, I agree.
Arthrogram is advocated because tend to miss a slab tear or a
Haggle.
on a plain MRI. So in this patient, we don't worry about haggle or a slab. But only one modification of Subramanian thing is, he said, try to treat this patient with rehab. I said, you must treat the patient with rehab.
Okay, for the benefit of all of us, Ashish, for the benefit of all of us, could you just tell your protocol, because I know you have a very robust protocol of treating these patients. Just briefly.
These are much more difficult to rehabilitate than your conventional stiff shoulder impingement patients because they have lost proprioception. It has been proven that the proprioceptors in these Pacinian corpuscles in these tissues are much lesser in frequency. So they don't have a proprioception. So like Subramanian said, we do everything on the rehab, right from scapular stabilization, core exercises, cuff strengthening, and in these patients, I warn my physios, just work on scapula for the first 5 days.
Okay, scapula for the first 5 weeks.
Cuff in the absence of a scapula. Scapula is
So that's a very important point. First is scapular stabilization.
Unless you stabilize the fulcrum, there is absolutely no logic in moving ahead on doing the cuff strengthening. We do a lot of dissociation and proprioception exercise along with it, and that's very difficult to teach a physio because you can tell them do cuff strengthening, but proprioception has to be inculcated. So that depends on the experience of the physiotherapist. Once they do that, and if the cuff starts strengthening, you have achieved everything. Because what happens is basically with these proprioception and scapular stabilization, the head automatically comes to center of glenoid. The moment that happens, all the length tension relationship is established between the scapulohumeral muscles, and the rehab becomes very easy. So if your patient has developed a strong empty can and a strong external rotation, you know that the scapula is stabilized and it has come to a point of neutral, biomechanical neutral position.
Okay, thank you. Okay, so when is the role of surgery in this kind of a patient? Say patient does not improve even after 1 year of spending, at Pune, patient has not improved. So what should be done then?
Me?
Yeah.
Difficult questions. Don't operate.
Don't operate.
When I was young, we did this. When we were in Liverpool.
Always said-
Thank you.
Actually,
You made my day.
the phrase is when I was younger.
When see, my English is getting rustic now. When we were in England, we used to get a lot of these patients, and people talked about secondary gain. And look at our practice; we never have patients of secondary gain because there's just no compensation in this country.
Yeah.
But I remember one case where she was sent from 3 different surgeons. First surgeon did a open bankard, second fellow did a putty plat, third fellow did something and then she failed and she was dislocating her. She got divorced, she had psychological issues, and then our boss did a fusion for her finally, and that fusion broke at distal end of the plate. So the
misery
saga continues.
continues.
So don't operate whatever temptation, even if the patient begs, you don't need to. If it doesn't work, change the physiotherapist. There is only one indication for operating such a patient. If they have a traumatic anterior bankard tear in addition to the MDI. So that's the third angle of the Bailey's triangle. Then yes, they do a nice capsular imbrication, repair the bankard because you have a structural problem there. But just because rehab didn't work doesn't mean that is the indication of surgery. Surgery is not a solution for everything that is failed.
So, if I were to take your word, so you have not operated on any of these patients in your last 4 or 5 years or so? No.
Absolutely.
MDI, no arthroscopic surgery. Any experience with open surgery, capsular shifts? No.
Never need. If I can't do it arthroscopic, I can't do it.
Okay. Kapil, you
I won't cross my heart on that. I have operated on patients where there was no documented lesion. But this girl who had a car accident where she had a jolt and her shoulder started slipping afterwards. There was all scans, everything else didn't show a lesion, but I have plicated her anteriorly and she's now 2 years down the line and doing fine.
So you do it without creating a bankard, because I remember you asked to offer that question, so you don't believe in that. Vivek, any experience of operating upon?
3 patients, and none of them have recurred.
So what was done? Could you please take the mic?
I waited for about 6 months, but they kept on coming, pleading. One girl was in
Yeah,
college.
they do come, keep on coming. Yeah, that's what.
And I told them that this will recur. The last one which I operated was about 1.5 years. Fortunately, till now they have not come back.
So you've done a plication.
Plication. One patient, as I think Ashish said, one patient had a subtle lesion in the anterior-inferior. Probably was secondary to the repeated dislocations.
Okay.
Other 2 did not had any major, so only lax capsule everywhere. So even I, don't want.
So the message which comes out is, Subramanian, you want to add anything?
No, I just sit and talk to the patient for a long time, advise, reassure and say.
Okay.
Please for not to-
So be,
If you
Yeah.
keep telling them you're going to redislocate again and again, probably they will stay away from surgery.
okay, yeah,
They'll dislocate in 5
yeah,
minutes.
please.
Just ask the panel one thing, if you have a structural defect in the anterior label, and you want to, it is a multi-directional, that means you are in the center of your very spine. To fix the bare pancart, do you do anything more?
No, take a bigger bite of the capsule.
Yeah.
That's it.
That's
I think
it.
plication should be
But
added.
360 or not?
No, 360.
No, 360.
No 360.
Anterior and inferior.
Don't do too tight a repair. You can convert the patient from
Anterior to posterior. Yeah, yeah, that's very
What I
important.
was trying to
It's
get
not.
at, yeah.
It's not.
And the
Oh.
other thing is these patients are usually lax, so they will hate you when you stiffen them too much. It makes the shoulder painful, so remember that as well. Don't tighten them too much. It's a shift from below. Don't, I tend not to put any ankle sort of above 3 o'clock or 2 o'clock. Avoid that area completely.
So what I can get from this case is the take-home message should be that the threshold for going for surgery should be very high in these cases, and you should try to rehabilitate these patients as far as possible. Now, this is case number 5, 18-year-old male patient, student, bilateral shoulder instability. It is habitual and there is no history of trauma. And he dislocates at will. So it's basically muscle patterning. Last, okay. So, and I think the other video is not working, but this is a habitual dislocator. And so what should the approach be in this kind of a case? I would start with Subramanian.
Again, it's non-operative.
It's a different case scenario from multi-directional instability. This is a voluntary dislocator. Yes. So no surgery at all.
It's non-operative.
No surgery at all.
Non-operative is,
Okay.
mainstay management.
Okay. I think Offer has spoken on this topic in the morning. So try to retrain the muscles and look for muscle patterning in these patients and try to build the antagonist, which and then maybe psychiatric evaluation.
All of them are not
and
painful. They do it as
yeah,
habituals.
yeah,
Not
yeah,
painful.
yeah, yeah, yeah.
But I beg to differ with that psychiatric part. We've had at least half a dozen such patients coming. We work on rehab and they do a fantastic response to PSRP. The patients have been poor guys, they're not street artists, they're vegetable vendors, they've not been psychological victims, we've not given psychological treatment to any of them. But in India, patients don't get secondary gain, so they're not going to do this for attention seeking.
Okay.
So
Okay. I think we'll.
honestly, we didn't do the scapular disc anesthesia talk, but I had 2-3 videos to show pre and post, and the results are within 4 to 6 weeks. The psychiatry is a big overdue, but when we don't manage it well and we think there's something happening in spite of our efforts, we tend to call it a psychological case, but that's not always.
But no big problems of patients that that want to stop working to earn money from the government.
In India, if you don't
working compensation.
No, that does not. There's no.
Oh, in India?
There's no compensation.
If you
There's
don't
no
work,
compensation.
You're a happy guy.
we don't get money.
Yeah.
So then what do work?
In India, nobody goes off work at 40 because of
Okay.
backache.
Okay. So with that,
Because of backache. Nobody gives up
Okay.
work.
okay. So with that, I'd like to thank my esteemed panelists. Thank you very much. So thank you.
Thanks, Amity, and thank you very much for the panel's active involvement. That brings us to the end of the day. For those interested, there is a workshop behind, and I'd
for the posterior portalis. It is the posterior lateral part of the acromion. 2 centimeter down and 1 centimeter medial. That's the point of entry for the posterior portal. Let's spread out a little bit. Can I spread out a little bit? Shoulder more. Spread out. Here is a patient is in that one. You can see. इसके थ्रू जाना पड़ेगा. अब ये नहीं. So the patient is supposed to be in lateral position here. Scapula down, arm over. Put the choker. Is there a choker? Now inside. Shoulder. Put the shoulder. I'll just show you once. So this is the lateral portal. that got किया हुआ है. So that's the humeral head. So first thing you see is where the biceps. I think they have put this as a biceps. There's a biceps. And there's the subscapularis. The two brown structures. Top brown structure is the biceps. Down under the subscapularis. In between is this triangle. Top, bottom. That's rotatory interval. This is humeral head. You are seeing the glenoid. Glenoid, that is the top of the glenoid, where it's about 12 o'clock position. This come 1, 2, 3, 4, 5, 6 o'clock. This is 6 o'clock. 7, 8, you can come slowly like this. Yes, superior. If you go over here, 5 o'clock. You put the anchor or the 5 o'clock is here. This is 3 o'clock. This is 6 o'clock. No, we will put it at the 5 o'clock. Anchor will be put around 5 o'clock.
Transportation is also.
Okay. So if you want to see the rotator cuff, this is the head of the humerus. You keep going up, that's the rotator cuff.
Yellow one.
Yeah. And if it is a heel sag defect, it should be here.
So how you will put the anchor?
So you need to make a
patient है that is already pressure पे लगा हुआ है तो उसको उतार के फिर engaging heel sag
engaging heel sag you identify by rotating the humerus. So you turn the humerus, abduct it like that. See whether this end of the
so traction so you have to move from the traction.
You don't have to take. We can just see patient already abducted. In the lateral position you have about 60-degree abduction. You just have to extend it. So that has to be done in dry. So for the second portal to put the anchor, it has to be in the rotatory interval, just below the tendon of biceps. I think they made a more. So you put a cannula there.
Going underneath the biceps?
So just below the biceps. So biceps is here, subscap is there, so in between those. You can use two cannula, one cannula just below the biceps, other cannula maybe over the subscap.
Where is the bicep tendon?
This brown structure is biceps.
Okay, that is subscap.
This is subscap. Okay. So you got to put an anchor at 5 o'clock, which is somewhere, I think they already put a thread switch there, so somewhere here. What do you have? Do you have a cannula? Give your bioraptor sleep.
We have to put it.
You can view from anterior portal, then you will see the heel sag defect even nicely. We don't have a cannula. If you have a cannula, it's easier to do.
Yes. You can, you cannot use without cannula. Otherwise,
So now,
your portal is minus 5.
in actual situation it has to be tapped first or is it directly
No, first
there
you
are
have to
various types of
drill.
cannulas available.
First you make the hole and then
You have
you
a
have
drill.
to tap.
And then where is the sleeve? You don't have the sleeve?
There
Give
is
the
no
sleeve.
cannula.
Give the sleeve. Where at the sleeve is there? Somebody can. The green one. That's the sleeve. So it's actually difficult in the model. It's easier in the human being. So, okay, now
They should put the cadavers. That would have given a better picture.
So now you have angle like this. Who wants to put a screw? Just hold this one for him. Just focus it nicely. Okay, first you have to make sure your angle is on the rim. It has to be about 2 to 3 millimeters. So there is a, if you see, that's exactly the right spot. Just about 2 millimeters away from the labral mark. Okay.
On the glenoid side, on the articular side.
Yes. Maybe we are too far this way.
It doesn't actually.
Go.
Yes,
The whole shoulder is moving for some reason. Okay. And
It's slipping.
Go. Right. You need to go until that laser mark. I think that's it. So now you are taking this out, do this like this, and take this thread out. And turn it around this way, so you see. Just pull this one, comes out easily. That's it. Now we just have
It has come out.
It has come out.
put it back.
Okay.
So now we just have to pull this. Yeah, that's it. So now you got a thread. Okay, what do you have? Parrot beak? What do you have?
Which one you have? Left or right?
So first we have to make a knot.
So this one will bite, will pierce the capsule and also will take the tissue. Okay.
Just pull it down. Surgeon model.
ये उसको रॉड को क्या कहते हैं जिससे कन्वर्ट कर दें?
The good one for this may be the one. This is a convex side opening. The concave side opening will be on that. You have the
It
one?
opens on the bottom.
So now you take a bite from one of these.
Ilk yavaş lazım. İyi geçelim. Açın. Bak, rotate.
You have the straight one.
तो इसमें जो नॉट बनाते हैं वो कैसे बनता है? स्लाइडिंग एंड
Easy.
हाँ
For sure. Put this one in here. Let's take the bite first.
Чего пока я что-то на эту потом. Сказать, только чувство.
It's a very flimsy this one. Yeah. Okay. So I'm just trying to take a bite from the labrum. So you see here, this labrum is very tough tissue. Normally it's not that tough as this one, which is not able to pierce it. It shouldn't be as tough like this. Now we are gone. So now gone back. Take it. So you have to go through and good. That's fine. So now go and capture one of those. You have to turn it and capture. Yeah, that's good. How to take it. That's very difficult. So what you can do is, if it is not coming with this, go out slowly, try to put it everything correct. Okay. Okay. Sure. Pull it out. That's it. So you got one end going through there, another end going through there. Okay. Now you just have to put a knot. How to put the knot?
First we'll retrieve these.
Yes. So you have a. Show it like this.
Other end.
Yeah. Just need that. We do Duncan now. Okay. So make this one is going to the capsular side. Okay. This one is in the bony side. Okay. This is the post. Okay.
Which one is the bone?
So this is going to the capsule side, labrum. Okay. This is in the bone side. This is in the glenoid side. Okay. This is the post.
So the one which is going in the capsule is the post.
So hold this. One full. Second full. Third is half each. And then the last one comes through this. Yeah. So now you have a knot here. You just have to pull this. See, not this. Should be. So pull it. If there is a cannula, those stitches will not come in place. So you tighten it in. Okay. That's it. That's a knot pusher. Yes. So the knot pusher can tighten it even further. Okay. This got the half inch. No, two bullies and half inch. I can't see it. Can you see?
So the thread this is the post.
This is the post. Go through it. There is a cannula, there don't any struggle. There's no cannula. So keep artery clip or something you have here. So usually I have artery here, where it holds it like this easily. 1/2 inch.
The post remains the same as the capsule wala is the post.
Yeah. Because there is no cannula and those stitches are coming on here. And then we put a reverse half inch. Okay, now take scissors and so cutting this. Show me. So this is a 5 o'clock, and then you can go to where is it? A lot of capsular tissue there. Okay. So then stitch there. Already there is no stitch there. So there is already a stitch in 3 o'clock, 4 o'clock, this is 5 o'clock, even 5:30 you have taken. Somebody wants to try this? I think labral repair is out of shoulder arthroscopy hierarchy. First is to learn the bursa, suboptimal bursa, like doing bursectomy and epimeoplasty. Next step is going for labral repair, like anterior labral tear repair, and then slap lesion repair. Then come for rotator cuff repair.
If you don't have this push-up arm, can we do the shoulder arthroscopy with the normal as we
Yeah, I do Bankert without force. Only for the rotator cuff I use it. North is keep this. You have one post. Yes.
The one you got your finger on.
सर ये ट्रांसपोर्टेशन में ना ब्रेक हो गए हैं।
No, just
बाई एयर मंगाया था तो
you got it on.
पैक नहीं किया इसको।
Maybe you should go.
बस जल्दबाजी में
This can cut your skin. You don't wear it gloves. These are fiber wires. You got to be very careful. This knot cannot be taken out. It's a good knot. You just learn one good knot. You can use it for all the cuff repair, everywhere you can use it. Yes. Use it. Absolutely.
Sure. So this is a good position? Sir, position.
Yes, good.
Tissue आ गया. Screw it in.
So if these structures come on the way like this, you can use a basket or something to take it out. Or sometimes
Upper angle. Right. Slip कर रहा है.
कल मूवीज इसी भी सिखाएंगे ना, पर नो कट वर्क।
चलो अब चलो.
don't carry was in hotels normally. You can't allow caravans in hotel. It has to be like
No,
this.
that is
You have to come to Bangalore, Ramaya Medical College. You do caravans.
This is smart photos. You are from Bangalore?
I go to Bangalore also to operate. It is something that we have
Yes, sir.
Cador shop.
Yeah, is that?
In Bangalore?
Yeah, in Bangalore. Yeah, Ramaya.
Only center in India is Bangalore.
Yeah.
When in the
We have in March.
fee for that?
We have in March.
March,
Yeah.
how much you charge?
So there are charges, different charges for the basic as well as advanced courses are there. So there are different charges. If you can just share.
Yeah, I'm doing
Speak to the guys.
This is this particular say conference is called folder, which is coming up in say March, basic as well as advanced. And if you can share your details, I'll forward you all the details of say courses. I then will connect with the
I think most of the names they will lend it. You need a lot of things.
So basic it is 8,000.
First thing you need is for cuff, because each individual companies
see,
have
first
different
initially
if you are going to use an anchor, you just ask
which is called entire everything like
what you need to buy. What you need to buy is
when it goes to advanced
Verification
pro, you can use the implant. Advanced. No, sir, yes, sir,
basically you need a console for license.
Reverse tube you are now using from this side?
Verification.
Same side.
Same side.
So the push-to pull you have the hook and the working hook is through the anterior.
So all the communication
Restaurant will give it from
okay. The company is with an we have a clears which is the medical education body and they will say separately.
Actually, the whole model is moving.
Scope set for the periscope, seat and option. How much close to the correct.
There are metal anchors available. Decent any price. I think
cheaper than this.
High definition. Which high definition? Yes, high definition.
Metal anchor doesn't cost 9,000. And you can use one single loader, one anchor, double loader, 2 threads. You take 2 by only 9,000.
Okay. Sorry.
The most inferior one is a difficult one. As you go up, come up, 3 o'clock, 2 o'clock, it's very easy. Because you're turning
anchor like they were showing camera, so they were discussing that we do it with the poster and
तो मैं आउटपुट देता हूँ आपको इसमें ले लेते सारा रिकॉर्डिंग हो जाती है
You put the camera from the front. and you can pass your instrument.
कल भी होगा तो आप काम करना ना इनसे इधर से आउटपुट ले लेना कैमरे से
So take your inferior most 6 o'clock by.
SBHS चाहिए YC चाहिए BNC चाहिए SDA चाहिए सब है ठीक
Working portal will be from the back. Viewing portal from the front.
इसमें नहीं होगा ना
6 o'clock. And also replacer, to do replacer,
मेरे पास केबल भी है आपका क्या BNC to BNC है
camera in the front.
सुनो आप इनपुट कौन सा लोगे BNC लोगे
Replacer,
Composite
solution is in the posterior superior.
ड्राइवर है वो भी है सब कुछ है
It's not that difficult in reality.
Yeah.
Here the level is plastic. If you can't use it, there are like future passes available.
Yes.
That is even more easier to do. It's like a needle.
How long does it take to
How long will it take?
How to start?
How to start?
Yes,
You have equipments?
ये हमारा
Start with metal anchors. Price is shoulder.
Yeah. Yes, sir.
full offload हो गया है ना
Yeah, offload. So this is what we need to be very careful that which is post and which is say
That is the issue. And
which is post.
एंकल निकल गया है
Okay. Okay. Yeah. Nothing.
ये
I
हमारा
don't need it. There are
एडवांस का फिर मार्च में
sports guys.
तब अभी हो रहा है
Not everyone gets any. The general population.
Yes,
Yeah, I mean, these are the better one to try. They are not the good one to try. And try it outside. So just
ड्रेस इट नो
it's very important that you should not.
before
But it will do. No, I'll try to show you here. Yeah. This is the best way to do it. Yes. Yeah, I mean, use it.
two different color also.
You can go to YouTube. YouTube gives everything almost. Plenty of them.
Slide on it.
Huh?
It should be slide smooth.
It's called sliding now.
Yeah, that's why it is called
Full
sliding.
slide, yeah.
this is the post ना this is the post
Yes.
and then उसको
Post is to start with it was short. At the end it will become equal.
The surgical knot, it seems
And then half
we
joints
are
are
in the
there.
training, it seems to miracle. And when we are accustomed, it seems very
This is simple.
Yeah.
this is the half inch then
Yes, yes.
one
And then reverse.
and then
one under and one over.
One under, one under.
and then we alternate
That's it. You don't need anything more than two. Sliding knot, one locking knot.
three knot, three knot.
you think then alternate the post and
No, first sliding knot and then one good knot, half inch. First enough mostly. I usually put two.
we don't need to alternate
Because
the
first
post.
sliding knot has to be locked. For locking you are putting a second half inch.
But you're not required to alternate the post.
One knot is good.
Okay, sir, thank you.
No problem.
Because
Thanks, sir.
it